This is TTT Live. I'm DK Rostar. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, and on Facebook at TTT Live Online. We go now to the manager of the corporate communications at the Ministry of Health, Candice Alcantara.
Good morning, and thank you for joining us for another Ministry of Health virtual media conference, which provides you with up-to-date and accurate information on the national COVID-19 response. Our panelists today are Dr. Roshan Parasram, Chief Medical Officer, Dr. Avery Heinz, Director of the Epidemiology Division at the Ministry of Health, and Professor Donald Simeon. He is a representative from NTAG, and CMO will give you more information about the National Technical Advisory Group. He's also from the Caribbean Health Center for Systems Research and Development, and a professor in the Faculty of Medical Sciences at the University of the West Indies. We will begin with an update, a clinical update from Dr. Parasram, and he will also give us an overview of the National Technical Advisory Group.
Hi, good morning, Ms. Alcantara, Dr. Heinz, Professor Simeon, members of the media, members of the viewing and listening public. So as Ms. Alcantara indicated, I will start with the clinical update for January 10th, 2021. Our total number of tests received thus far at both private and public facilities, 74,912. Our new positives reported over the last 24 hours are 21. Total positive cases from March 12th to present, 7,265. Our total number of recovered patients now stand at 6,857, giving us a total active caseload both in hospital and in the community at 280, with a total number of deaths standing at 128. In terms of our hospitalized patients, we have 23 persons at all institutions, 16 persons in step-down. In terms of quarantine, 348. Total persons in home isolation now stand at 220. So to go a little more into detail with regards to the hospital patients, at the Couva Hospital and Multi-Training Facility, there are 17 persons in the ward. There are 3 persons in ICU at this time. At the Cora Hospital, 2 persons. St. Anne's Hospital, 1 individual. And at the Scarborough Regional Hospital at the Fort, there are 3 persons, 1 en route. With regards to our step-down facilities, our Claxton Bay Correctional Facility is now empty. The UE Davie facility is housing 13 persons, and in Tobago, in their step-down, there are 3 persons. So we have quite a full house in terms of our quarantine facilities. As I said before, 351. So those persons are spread between a number of facilities. The Chancellor Hotel, 23. Cascadia Hotel, 38. Homer Football, 18. Regent Star, 16. Paria Suites, 29. Davie Halls, 2. At the UE Canada Hall, there are 42, UE Freedom Hall, 75, and Cara Suite, 6. Cape Hawk Hotel has 102 persons at this time. With regards to the national tag, just to give you a little background on the national tag, so as Ms. Alcantara indicated, it's a national technical advisory group that advises basically the Ministry of Health. It's chaired by the CMO, has been in existence for many years prior to COVID. It is a vaccine advisory group. So basically, its membership includes pediatricians, consultant pediatricians from across the sector. We have nurses. We usually have the manager of the expanded program for immunization, which is a Ministry of Health post on that group. But for this particular vaccine, COVID-19, we have created some ad hoc positions, and Professor Simeon, who is here with us this morning, is a statistician by profession, and he's been included in the group as a member from UE, as well as Professor Carrington, who is here. She's included as a virologist. And we have Professor Montai as well, who is an immunologist. And she has been working a long time in the North Central Regional Health Authority with regards to immunity and immunology. So we have expanded our group to have a quick look at the COVID vaccines, and they continue to do so. The University of the West Indies has also established another group which is looking at the research aspect of it, and Professor Simeon may touch on it this morning, but we have expanded that group. So the way it works is that Trinidad has a national tag, Above us, there's a regional tag and there's a WHO tag. So information filters down through the regions from WHO to the regional tag. One example of a recent decision that was taken by the tag, if you remember a couple of years ago, the measles, mumps, rubella schedule would have been at 1 year and then at 3 years. That had been changed in recent times based on research that suggested that the immunity would be better placed if we actually had the vaccine lower, closer to the first dose. So we took that decision about 2 years ago to bring the first dose of MMR to 1 year and the second dose to 2 years. So similarly, we continue to have that tag. We meet usually every quarter, but for COVID-19, we are meeting more often, and we establish a sort of virtual meeting group. So when Professor Simeon speaks, it is in that context as a member of the tag group as well. Ms. Alcantara, that's the clinical update for this morning.
Thank you very much for that clarification, CMO, and a very good indication of the kind of collaborative efforts that are happening as we address COVID-19. And now we go to Dr. Heinz, who will give us the epidemiological update. And he will let us know if there are trends, if there are any trends, post-Christmas and New Year festivities.
Thank you. Good morning, Ms. Alcantara. Good morning, CMO. Good morning, Professor Simeon. And good morning to the members of the media, viewing and listening public. The epidemiological update for today, up to yesterday, as at the 10th of January 2021, is as follows. Let's have the slides. Thank you. Next. We'll first review the 2020 data, just looking at the end of 2020 as at December 31st at 4 p.m. when we had confirmed 7,150 cases, which included 127 confirmed fatalities from the disease, giving us a case fatality rate of about 1.77% at that point in time. The numbers or the figures by month for 2020 are displayed here, giving some indication of where there were clusters or events of interest. So we will see that the light blue bars show the monthly tallies. The orange strips that accompany some of the bars indicate points at which there was a special cluster that contributed to the monthly tally. So beginning in March, we would see that there was that cruise ship cohort that we referred to frequently in the early stages of the local epidemic, and some of those cases actually also showed up in April. So you see the call-out labels, the ones that are in squares, indicating the numbers of cases that belonged specifically to that cohort. We saw that we had a decreasing number of cases from March through April, May, June, minimal, and then we started to see increases from July, really the end of July, go into the remainder of the year. We also see that there's a line with red dots with labels, and that line with the red dots indicates the number of fatalities that would have occurred in each of the months. So it's really just giving a very quick snapshot of cases, clusters, and deaths that would have occurred from March through to December. Seeing the low numbers in March, minimal in May and June, July, August, September, an increase, and then a decrease towards the end of the year, month on month, fewer cases. That's the 2020 situation. Now, looking at the epidemiological curve, the epi curve, next slide, we would see the now familiar epi curve with the colors by month, starting with the light blue in July, the increase in purple in August, and then September, October, November, the blue, green, and orange, coming down, that big peak in November representing that prison cluster that had nearly 200 cases in it. And then December with reasonably low numbers throughout, and that dotted line rolling throughout the background of the graph representing what we call the rolling 7-day average. Now, as we move into 2021, what we're going to do is keep some of this background data as context. Next slide. We're going to grey out 2020, and we're going to begin with the data for 2021 over on the right-hand side and basically frame shift. So we will see the new cases basically coming in from the right, and we get an idea of the current trends based on the colored sections. One current trend that we have noted in the past couple of days, meaning over the past 2 days specifically, is that we're now beginning to see slightly larger numbers of cases per day than we had seen throughout the early part of the year, throughout the first 7 days or so. So whereas we had between 8 and 12 cases most times per day, we did note that there were cases rates rising into the 20s, 25, 21 over the past 2 days, and this may very well be as a result of any of the gathering and congregational activities that may have occurred 2 weeks ago. 2 weeks ago basically being the beginning of the Christmas festivities, the 25th of December come forward. We are hoping that this doesn't establish itself as a rising trend, but we do note the beginnings of an increase, and we do note that they may very well be related to whatever activities took place behind the scenes over the Christmas period. We will continue to monitor and will continue to advise. Next slide. The demographics remain largely as they have been in the past, with slightly more men than women, 54% male as opposed to 46% female, and the majority of the cases belonging to that 25 to 49-year-old age group. Next slide. Among the deaths, the trend also remains similar, with just about 74 to 75, three-quarters of the fatalities being among men, and the majority of them being above age 60, noting well that most of the individuals who had a fatal outcome also had coexisting chronic conditions, meaning whether they had diabetes, hypertension, or other things in the background, and also noting that there have been deaths in younger age groups as well, so that we know that no one is immune, no one is assured of a positive outcome, and we want to ensure that everybody takes all the necessary precautions to prevent themselves from becoming infected. Last but not least, the geographic distribution. Again, this is over the last 2 weeks, the last 2 epidemiological weeks, so the last week of 2020 and the first week of 2021. We're seeing where the cases are quote-unquote concentrated. Although they're small numbers, the darkest numbers referring to maybe 3 cases in a community over that time frame. What we do note is that where there are concentrations of individuals, where there are larger populations, we have seen more cases, and that the cases are pretty much spread out across various counties within the country. So we do want to continue to advise everyone everywhere to adhere to the public health guidelines and to adhere to all of the recommendations with respect to not going to work when you're ill, wearing your masks, maintaining your physical distancing, and basically staying the course as we continue to push back against the spread of the COVID-19 virus. With that, I'll turn you back over to Ms. Alcantara.
Thank you very much, Dr. Heinz. And it is my pleasure to welcome for the first time on the conference Professor Simeon. And he will let us know about the role of the Caribbean Center for Health Systems Research and Development as it relates to COVID-19 vaccine decision making. We go now to Professor Simeon.
Thank you, Ms. Alcantara, Chief Medical Officer, Dr. Parasram, Dr. Heinz, the Director of the Epidemiology Division of the Ministry of Health, members of the viewing and listening public, members of the media, good morning to everyone. Can I get the first slide, please? Wait, next slide. Yes, I'm glad that I was invited to be first part of the National Immunization Technical Advisory Group by the CMO, as well as, of course, to this morning's press conference. I am, as was said in introduction by Ms. Alcantara, I'm Donald Simeon. I'm Professor of Biostatistics and Research, as well as Director of the Caribbean Center for Health Systems Research and Development. And of course, it's within those roles that I perform that I was invited to be a member of the Technical Advisory Group. Next slide. I will just be presenting quickly what research is being done at the Faculty of Medical Sciences in the area of COVID, including our virtual symposia that were hosted for the last few months, a bit about what we are doing in the area of COVID response and research at the CCHSRD, as well as critically the vaccine report that was recently prepared by the Faculty of Medical Sciences and presented to the CMO. Next slide. In terms of research, the Faculty of Medical Sciences established the COVID-19 research group back in April of 2020, which has been meeting regularly over the period up until now. Our next meeting actually is on Thursday, which will be our 24th meetings. We have met quite a bit. Over that time period, our members have completed 15 research studies in the area of COVID. 6 of these studies have been published in international peer-reviewed scientific journals or presented at conferences. And we also have 5 ongoing studies and 8 studies that are awaiting approvals or funding so that they can start. Importantly, we have been working closely with the Ministry of Health in a number of areas. For example, there are 2 ongoing research studies in which we collaborate. One is the Solidarity Trial, WHO Solidarity Trial. The second is the COVID-19 Impact, which is a study that is led by Professor Christine Carrington. We have also proposed 5 additional research studies that we would like to work with the Ministry of Health on, and of course we look forward to their positive response and of course working with the ministry. Next slide. We held about 5 virtual symposia to date that address COVID-19. That is, we at the Faculty of Medical Sciences, UWI, as well as the CCHSRD. The first was hosted back in May 2020. It focused on the impact of COVID-19 on health systems. The second was in June, in which we did a symposium addressing navigating the safe return to dental practice, a new normal. The third was COVID-19 effects on the population and population health in the post-lockdown era. This was done right after the first phase of the pandemic. Then we had one entitled Animal Lovers and COVID-19, What You Need to Know, that was held in July. And the most recent one was the UWI St. Augustine COVID-19 Research, Evidence to Inform a Multidisciplinary Response to the Pandemic. Importantly, we plan to host a symposium by the end of this month looking at the vaccines, the COVID-19 vaccines, and of course you'll get more information about that, in the next few days. You can get information from the UWI Faculty of Medical Sciences and the CCHSRD websites, as well as the various social media. Next slide. At the Caribbean Center for Assistance, Research and Development, the CCHRD, we have 2 core functions really. One is the conduct of health policy and systems research, and the other one is to facilitate the utilization of the best available research evidence in decision making by policymakers and health systems managers. Importantly, we also have an MOU with the Ministry of Health to support evidence-based decision-making at the ministry. So of course, this is very critical in a time of COVID. In terms of COVID-19 research, we at the center have completed 2 research studies. One is preparedness of primary healthcare facilities for COVID-19, and the second is an assessment of the health system's response to the pandemic. These papers, one has been published in a journal, the other one has been presented at the National Health Research Conference that was held in November of last year. We also conduct evidence syntheses, that is, to identify the evidence related to pressing problems, health problems that the ministry may have, and of course we are available to produce rapid response briefs to relevant COVID-19 topics. I will then talk a bit about a recent report, a report that was completed just last week and was submitted to the CMO last Friday. It was prepared by the UWI St. Augustine Committee for Vaccine Efficacy. This is a committee that was convened by Professor Simongo, the Dean of the Faculty of Medical Sciences, and led by Professor Yuri Clement. It reviewed the range of vaccine types and summarized what is known about their efficacy, their safety, the quality and duration of the immunity, and delivery and storage requirements for each of those vaccines. And importantly, it also addressed strategies to increase vaccine uptake by the public. As I said before, it was submitted just Friday to the CMO and is ready for use by the NITAG, by the National Immunization Technical Advisory Group. I won't say any more about this report because, as I said, it was submitted to the CMO and, of course, it reviewed by the Immunization Technical Advisory Group. And I'm sure you will hear more about this report and the findings, of course, recommendations in the near future. I will end at this point. Thank you.
Thank you very much, Professor Simeon. And we go into our question and answer segment at this point. A reminder to media representatives, please state your name and the media house that you represent before posing 2 brief to the point questions, please. And just pose 2 both at the same time. It'll help things to flow a little better. And we start right now with questions from TV6, please.
Hi, good morning. Alicia Boucher from TV6 News. I have 2 questions. The first is, throughout the COVID-19 pandemic, it was said that the virus was affecting minority groups disproportionately at a higher rate, such as Africans and Latinos. But according to the CDC, Blacks accounted for only 9.8% of the clinical trials, and in the case of Moderna, minority groups altogether accounted for only 1/3 of clinical trials. Given the makeup of our population, which is predominantly Indo and Afro-Trinidadian, should we be concerned? That's the first question. Also, a doctor in Florida is reported to have died weeks after receiving the Pfizer-BioNTech vaccine. His wife said that 3 days after he received the shot, spots started coming about his skin, indicative of internal bleeding. It is said that thrombocytopenia in children in rare cases was linked to measles, mumps, and rubella vaccines. So I just want to find out are there any concerns that we should have at this point in terms of, what the experts think?
Okay, thank you for the questions. I will take the first question regarding the ethnic distribution of both the complications from the virus and then the actual vaccine testing. The statistics that you're referring to actually are the ones coming out of the US and the UK. We know for sure that within the US, the access to health care and the general health status differs between ethnic groups, with the quote-unquote minority groups having disproportionately lower access, disproportionately worse baseline health, and disproportionately worse outcomes for several health factors, including maternal mortality, including deaths from diabetes, etc. And it's not a surprise, therefore, that that disproportion also manifests itself in terms of the outcomes with respect to COVID-19 disease. Now, the population structure is such that they sort of represent the population as it stands when they're doing their trials. So they have represented their population proportionately with respect to their minority and non-minority groups, which is why you would find that if you're seeing smaller numbers or smaller percentages of minorities within the vaccine trials. Having said that, having represented various ethnic groups and having defined a safety profile that indicates that the vaccine is safe across the board, having included not just various ethnic groups but various age groups, various individuals with various background conditions, we do believe that the sum of the evidence indicates that the vaccine is safe for the majority of the world population, several ethnic groups having been tested, and within our system where we don't have that issue with disproportionate access by ethnicity, etc., and where our Afro and Indo groups are not the minorities, some of those concerns with respect to minorities don't really apply. We do continue to look at the individual information coming out of various studies, and we do continue to monitor whether there are differences in outcomes by ethnic group. So far, the safety profile has indicated it is safe for all persons and that it's also effective across groups. So I hope that answers the first part of the question. I will allow CMO to respond to the second.
Yeah, so we are aware of that particular incident that occurred, I believe it's in the US, where one person had an adverse reaction, not necessarily to the vaccine, but after the vaccine was taken. So far, I believe there's upwards of 1.8 million people that would have taken that particular vaccine in the US. That is one incident that is being investigated by both the manufacturers of the vaccine as well as the US agency, I believe it's CDC, that will be doing the follow-up for adverse reactions. So it's a very, it's early on in that particular instance that you noted. However, we need to wait and see what the findings have been to see if it was attributable to the vaccine or attributable to some other disease. What happens is once you have someone taking the vaccine, they are asked to report any signs and symptoms of any disease that they would have thereafter. So what happens in the normal course of reporting is that you will report anything that happens. It is then, the onus is now on CDC or the vaccine manufacturers to look at these particular symptoms that they get and go backwards and see if they are attributable to the vaccine itself or to some other disease that would have occurred naturally without the vaccine. So that is in process for that particular case. And of course, once we get the findings, we will share that with the national community. Candice?
Thank you. And we go now to Express newspaper for a maximum of 2 brief questions, please.
Good morning, Kim Bodram from the Express. My questions might be primarily for the CMO. CMO, at the weekend, the Express had an editorial calling for the exemption policy to be well updated in the form of being scrapped. And the IATA, the International Air Transport Association, it seems when we look at that, we see that Trinidad and Tobago might be the only place left in the world with a type of policy where people are bottlenecking through a sole authority, which is the Ministry of National Security, to get back into the country. So hoping not to ask a twofold question, but you know, is there anything from your health perspective, because we know that it's being governed very heavily by, you know, the COVID-19 situation coming into the country. Is there any update you can give or any opinion on updating that exemption policy in that way? And could you share with us at all how the hotels for quarantine, private hotels, are chosen, if health has any input into that? Also, at the weekend, we saw a private party in a private property in Chaguanas at a restaurant. Over 70 people were there. They were not wearing masks, and the police did, in fact, go in and stop the party and ticket people. But it seems that there's a gray area remaining with private properties and parties, and whether or not persons ought to be made to pay what they can and cannot do. So we saw that last year, and coming into 2021, any update on maybe looking at laws to govern these types of activities on private property, and also to ensure equity?
Thank you very much, Ms. Boudram. Thank you, Ms. Boudram, and we go to CMO now to respond.
Yeah, so the first question regarding exemption, that lies with, that whole process lies with the Ministry of National Security, so I wouldn't want to comment on that matter at all. With regards to the private hotels, the Ministry's role, Ministry of Health's role in selection would be an inspection that will occur. Normally comes under the remit of the PMOI together with the Chief Disaster Coordinator, as well as the County Medical Officer of Health for that particular area, wherever the hotel lies. They will do an inspection based on a criteria that was set out by the Ministry and a tool that was developed and adapted from a PAHO guiding document. So we do a site visit, we do an inspection, we look at the number, simple things. We look at whether the persons can be well isolated within those divisions, whether from a Defence Force perspective, of course, Defence Force goes along with us and they look at the security aspect of it as well. But that is our role in terms of the Ministry of Health as it relates to those private hotels that are chosen for quarantine sites. In terms of your private property, that is a matter for the Trinidad and Tobago Police Service. I know the Honourable Minister of Health would have dealt with this question before relating to legislation and has said that that is a matter for the Attorney General as well. Thank you, Candice.
Thank you very much, CMO. Questions now from CNC3, please.
Hi, morning everyone. Rashad Khan here from Guardian Media Limited. CMO, I'd just like to touch on that last response you gave there. Now, throughout the course of the pandemic, we saw isolated incidents of people gathering and basically not adhering to the public health regulations. But it seems that of lately, we are seeing it become more of a trend. So I don't know if on the ministry side, you all have an explanation for why it is that we're now seeing so many people choose to gather in large numbers. I mean, over the weekend, we saw the situation in Tyrico and even that birthday party that happened in Shogunas. Is this a case of pandemic fatigue, just sitting in and people just saying, you know what, I'm fed up being home? And is the ministry planning on doing anything about this? And my second question is just for an update on the antigen testing that we're supposed to start sometime soon.
Thank you. And we go to Dr. Heinz for a response. I think those are best.
Okay. Thank you, Mr. Khan. Now, I'll start with the end of your first question and move backwards. Whether we're tired of the virus or not, the virus is not tired of us. And while we can't account for why individuals may be choosing more and more frequently to fail to adhere to the public health guidelines, what we can tell you is that that behavior will show itself in increasing numbers of cases, as we are already beginning to see over the last couple of days. As behaviors like that continue, what we do is we put the population back into a situation where there are higher levels of viral circulation within the population with all its attendant consequences. And this is a situation that I'm sure we'd all like to avoid. So whether there's fatigue or not with respect to the guidelines, whether there's fatigue or not with respect to the adherence to all of the recommendations, we still do need to maintain the behaviors that have been advocated for very heavily and strongly in the past, because as soon as we stop, we see the change 2 weeks later within the epidemiology of the virus. That, I think, is the most important concept to take away from that bit of the discussion. We need to hold the line, we need to keep the guidelines, and when we change it, we do see changes in the numbers, as we have already begun to see. I'll turn the rest of the question over to CMO.
Okay. So with regards to the antigen update, so as you know, the antigens are in the country, have been in the country. They're undergoing a process of validation. PAHO has contracted a consultant to do that validation. So there's a team that is doing that now. We had a bit of not a slowdown because of something we could control. What happens is when you look to validate any particular test, you have to have a certain number of positives and negatives samples by which you can run the test in parallel to a PCR test. So because we actually had a slowdown in the number of positives that we were getting in the early part of December and the late part of November, they weren't able to get the number of tests, positive tests, that they needed to complete the validation process. We have met with them. They have given us some indication that that process will take another couple of weeks. Of course, with the recent positives that we have gotten, it may be actually quicker because they can reach their endpoint more quickly. Once they complete the validation process, then we will get that straight into use at all our institutions. So we hope we can probably give an update on that in the next couple of weeks in terms of a firm time.
Thank you very much, CMO. Some side effects of reduced numbers there. We go now to Wyatt 868, please.
Hi, good morning, everyone. Fiola Bostic from Wyatt 868. My first question has to do with testing that the ministry reported on during their updates. There was a jump of around 1,600 tests between the 4th and the 5th of January, as opposed to the other days where we see like a change of 100 tests or much lower than 1,600. So I was just wondering if there was a reason for the increased testing at that time. Secondly, right now, Trinidad and Tobago, we do about 10 tests for each confirmed case. So I'm just wondering how confident are we that is giving an accurate picture of this true spread of the virus, given that so many of our policy decisions are made based on the numbers of the cases that we have.
Okay, then let me see if the first instance, I think we have to look into that. So we will have a look at the figures to see if there was that great jump, and then of course look to see what the explanation was. So we'll have to come back with an answer on that one. With regards to the second question related to utilization of the numbers on a daily basis for policy, we look at the trends. We don't look at raw numbers. As Dr. Heinz would have presented, we have trends in epidemiological picture, usually linked back to singular events or to events over a period of time. We don't necessarily look at the raw numbers, and we'll analyze it based on what we find. The 10% that you're speaking of, it is 10% of this total number of people that would have presented with viral-like symptoms and been swabbed. So it is 10% of the persons presenting to us. It is not a positivity rate in the population at all. If we were to swab all patients in the population who have absolutely no symptoms as well, and then you get a certain percentage, that is a positivity percentage for the population. So it can't be attributed. All we can say is that 10% of the swabbing that is done usually turns out positive, and that has been the case for quite a long time now, from July to present. So the policy decisions don't necessarily mirror what is happening in that regard, but we do look at the numbers over a period of time. For example, the 7-day trend, and we look at events that would have occurred. For example, restrictions imposed. When we had mask wearing come into force, we would have seen a positive drop in the number of cases thereafter. So we look at events, and we don't look at the numbers in isolation. We look at the entire picture, then we define our policies based on that.
Thank you, CMO. And as you know, we have questions from the public at times. We had some questions come into us, and we're going to address some of them this morning again. Question 1. Why is a vaccine necessary if we can follow the COVID-19 protocols like mask wearing and social distancing to prevent the virus from spreading? Dr. Heinz?
Okay, thank you for the question. Now, the vaccine is an important tool in the public health response to transmissible disease. What the vaccine will do is it will give added protection, especially to individuals who are at higher risk of severe disease because of comorbidities, because of increased age, because of occupation. They may be at higher risk of exposure. Those higher risk individuals are the ones that you want to give additional protection to, and the vaccine has been shown to reduce the risk of severe disease. In all of the trials, it has been shown to reduce the risk of presenting with symptoms, and even if you did subsequently show up with antibodies indicating that you had been infected, the severity of the infections was shown to be much less. So the vaccine then really adds additional mitigation, meaning blunting the impact of this virus passing through the population, and it is another useful and necessary strategy alongside, but not replacing, all of the physical distancing and other public health measures that we have been advocating. So it adds a tool, it adds a layer of protection, it helps to protect those that are most vulnerable and those that are most exposed, and it's definitely something that we'd want to take advantage of when it becomes available.
Thank you, Dr. Heinz. The next question, we've been getting quite a lot of questions from persons with non-communicable diseases like diabetes. And so the second question says, I have diabetes. Am I eligible for the vaccine?
So certainly, diabetes is a condition that we recommend. It's a non-communicable disease, and those with NCDs are recommended as our should be in our part 1 of our phase 1 response to delivering the vaccines, including as well healthcare workers, frontline workers. So NCDs, other NCDs, for example, hypertension, those with cardiovascular disease, would be part of our initial target for vaccinations once the vaccines arrives to Trinidad. So definitely, someone with diabetes should be given the vaccine, and they are one of the vulnerable populations that we have seen significant % of the deaths occurring in Trinidad from. Yeah, Candice, so the answer is yes.
Thank you. And another set of questions we're getting from persons who are concerned about their elderly loved ones. And so this question is, my grandmother is 80 years old. Is the vaccine safe for her to take?
Yes, so again, the elderly, persons over 60, form part of our target group. And of course, 80 is, again, we have seen significant mortality in the over 80s, and they will form a part of the vulnerable, very vulnerable group, I think. So it is essential that persons of that age generally have the vaccine. So yes for that one as well, Candice.
Okay, great. Thank you very much, CMO and Dr. Heinz. We go now to AZP News. We're ready for your questions, please.
Hi, good morning. Priya Bihari, azpnews.com. My question is this morning for Dr. Heinz. Dr. Heinz, in the map of Trinidad, there is the dark areas I see now in central and northwest. A few weeks ago, it was in south. Can you say why these things move? Is there any particular event or events that causes these clusters of grouping? And my second question has to do with the bar chart you showed, where I think in the month of September, there was the highest number for the year of COVID-19 cases. Can you say why that was the case? Has the ministry done the analysis and why that particular month had the highest number of cases? Thank you.
Okay, thank you for the questions. To explain the map in a little more detail, I don't know if we can put the map back up, but what we just see is which communities happen to have the largest numbers, raw numbers, of cases at any given point in time, not necessarily indicating, sorry, that's the bar chart. I'm talking about the map of Trinidad and Tobago with the colored polygons in it. Which communities in Trinidad and Tobago may have had the largest raw numbers of cases at any given point in time. And at this point in time, if you look at the legend, that's the correct one now. If you look at the legend, you'll see that the largest numbers of cases are actually still quite small in that past couple of weeks. So the biggest number, although you're seeing a dark red color there, it's still just 3 cases in that particular community during that time frame. And that will shift randomly as people turn up. So it isn't indicative of a particular trend of disease moving through the population in a direction. It is just indicative of what is happening numerically at a community level, so we can see where the most cases were shown at a given point in time. Now, with respect to the second question and the bar chart, I think that was a monthly bar chart. We can put that one back up. That was slide number 1. No, go back one. Backtrack. One slide before. It's easier to see on the monthly, although you can also see it here. But yes, so what we saw is that increase moving from July through August into September. And as we are aware, as we have stated on numerous occasions, all of the mass gathering events that would have occurred during that early part of that period, late July, early August, would contribute to higher probabilities of infected people coming into contact with susceptible people, and that is what drives the explosive transmission of a virus through a population. So what you saw is the side effect of several mass gatherings and failure to adhere to physical distancing and mask wearing. What you saw actually as a result of the imposition of mask wearing is the drop-off that happened thereafter. So as we imposed mask wearing, we did see that we began to have fewer and fewer cases. So that basically does represent the expected pattern if we don't adhere to the guidelines, and we would want to take the opportunity to advise the population that we'd like to avoid similar situations in the future, although they are still possible. So we still need to avoid the gatherings that we've been advising against. So thank you for the opportunity to make that point yet again.
Okay, great. Thank you, Dr. Heinz. Just a reminder to members of the media, we also have Professor Simeon here with us, subject matter expert, and a very good opportunity to raise some questions with him. We go now to Loop TT, please.
Morning, Alina Dudnath from Loop News. Just a quick question on the arrival of the vaccines. I know that Minister Delson referred to the arrival of 50,000 vaccines with the intent of serving 25,000 people. That calculates to about 2% of the population, and I know the intent was to vaccinate 20%. Can you give us a timeline on the rest of the 20%? Also, is there any timeline for the completion of the setup of the chillers and other equipment for the vaccines? Thank you.
Yeah, so the 50,000 that Minister alluded to is an early delivery that we are trying to get, and those will be not for any sort of herd immunity. Those are to deliver really primarily to the first target group, which is the healthcare workers, possibly persons from the geriatric homes, as a first part one of the phase 1. So that is in process. As Minister would have indicated, we are signed up to both the COVAX facility as well as we are continuing bilateral talks with vaccine manufacturers from different parts of the world to see how quickly we can get it in. We had all spoken about having vaccines in within the first quarter of the year, and we are keeping that timeline in mind as we have our discussions both bilaterally and through COVAX. We had a meeting with PAHO this morning as well to just get updates as to how that is proceeding, and we of course trying to get the vaccines here as quickly as we can. With regards to the state of readiness, we are looking at readiness for multiple storage conditions for different vaccines. For example, we are looking at the 2 to 8 degrees. We are looking at the minus 72, for example, like Pfizer, and as well as the minus 22 storage conditions for other types of vaccines. So we are trying to have 3 separate tracks of storage as well as distribution channels put in place, and we are in a position right now, if we do receive any of those vaccines, to actually be able to store and distribute them adequately to the population. So, and we are building on that capacity as we go forward. But we are in a position to distribute if we do get vaccines, let us say, within the next couple of weeks.
Thank you very much for some of that reassurance, CMO, and just demonstrating the proactive steps that are being taken on a continuous basis to ensure that we manage COVID-19 effectively and safeguard the health of Trinidad and Tobago. Want to go now to Newsday, please. I believe Newsday has some questions.
Hi, morning. Clint Chandrack of Newsday. Couple of questions I have. Firstly, given the concerns being raised about possible increases in gatherings and potential spreader events, is there a concern that as we enter a period which normally would have been a pre-carnival period, is there a concern that we might see a spike in these types of events? Because apart from the gatherings we saw, for ones which were mentioned earlier, I think there was some sort of FET event that was broadcast on social media where people didn't seem to, even though they were masked, they didn't seem to be adhering to certain types of the protocols. That's the first thing. And secondly, do you think that the measures which are in place to enforce and monitor these potential spreader events are effective enough, and do they need to be intensified? Thanks.
So I mean, in general, we are concerned with any event occurring during a pandemic that causes people to congregate in large numbers and don't abide by the guidelines, meaning that they don't wear masks and they don't abide by social distancing. So we are concerned with any event, whether it be Christmas or any other event that occurs that causes that to happen, because inevitably you will get an increase in number of cases. You will get an increase in morbidity and mortality from COVID-19. It will spread from one person to another. There's no COVID-19 will take the advantage of those scenarios to move between persons very readily. And as you have seen for other parts of the world that have the new strain, actually, it is moving much more quickly between people in those scenarios. So as a general rule of thumb, we again want to remind the population that we should not have gathering in excess of what we have in the public health regulations. We should always, and even though we gather in those places, we should still wear our masks and still have social distancing occurring. So there's always that underlying concern from the start of the pandemic, and it continues to date.
CMO, if I may, just to add to exactly what you just said, while we're speaking about not having gatherings in excess of what's recommended, we're not recommending gatherings. We're saying that we don't want people to gather at all, and that if you end up gathering because of some necessity, that we keep the numbers below a certain level. It's a very good opportunity, and I'm thankful to Mr. Chantak to point out that as we move into what would normally be another mass gathering season, we really have to refrain from our customary activities. We can't cheat the virus. There aren't loopholes that we can exploit that will allow us to escape the consequences of inadvisable gatherings. Whatever we do will show up in increased numbers if we don't abide by the very strict guidelines that we have been holding to The guidelines have been keeping us relatively safe with respect to the numbers, but if we fail to adhere to them, then again we'll start to see the kinds of increases that we would very much like to avoid. So just taking the opportunity to circle back on that and advise that we continue to stand together by staying apart.
Thank you. CMO, you had an update for
No,
us
just on a question that was posed to us
rate.
before regarding a 1,400 jump that we would have seen. So as I indicated before, it turns out that it would have been, normally what happens is that there's a weekly update from the private sector that comes to my office, usually on a Friday evening. So we get the positives every day, sometimes by WhatsApp real time. But on a Friday evening, I had asked for a summary from the private institution. So if you see a considerable jump in the number of submitted tests, those will be from the private sector from the preceding week. And that is what occurred in this particular instance between January 4th and January 6th.
Okay, great. Thank you, CMO. And we have a follow-up question from TV6, please.
Okay, so I just wanted to ask, over the weekend, we saw stranded nationals in Barbados who could not board a repatriation flight as they were unable to get their PCR test results in time due to an alleged backlog in Barbados. Is there anything that we can do to assist citizens in that predicament? And what is being done with this particular case? I don't know if you know that we can assist in getting or testing or getting results.
So it is difficult for us to assist persons outside of the country. Our national policy remains having a PCR 72 hours prior to coming into the country. So it is difficult for us to have that kind of relationship outside of Trinidad to get persons tests where tests may be difficult to find even in the private sector. But where there can be talks, for example, with CARICOM neighbors, we will try as much as we can to assist.
Thank you, CMO. And we go now to CNC3, Guardian Media Limited, please.
Hi, thank you again for the follow-up. So really quickly, so you said that we are going through COVAX facility as well as outside of the COVAX facility for vaccines. So is there then the possibility that if we happen to get a vaccine outside of COVAX facility, and then we come and get one from the COVAX facility, that we'll have two different vaccines circulating within the population, and does us getting a vaccine outside of the COVAX facility compromise our ability to get vaccines from COVAX?
So the answer to your second question is no. So there won't be any compromise. So the COVAX facility is something that we have a down payment for. That process will go by as normal for us to get our first tranche of 20% and then leading up to the 33% of the population. The first question that you asked relating to having different types of vaccines, as you have seen in other countries in the world, UK and the US, they have procured different types of vaccines and are giving it throughout the country. It is very possible that we may end up having more than one vaccine in the country. To assure the population, whatever vaccines we do get has to be first WHO approved, and of course approved by our national TAG group as well, and they will be go through our National Drug Advisory Committee to have vaccine approval as well. So there are stringent regulatory approvals that has to occur, so they will be deemed safe and efficacious all the way from WHO down to our national levels, whatever vaccines we use, but there is a possibility that we may have more than one vaccine in Trinidad for use as well.
Thank you very much. And we go to Wyatt 868, please.
Hi, good morning. Just one quick follow-up question. Could you remind us when someone tests positive for COVID-19 and the contact tracing is being done, do the people that are found during the contact tracing process, are they also tested?
Okay, so yes and no. Depends on the nature of contact. So there are primary contacts, secondary contacts, tertiary, all the way up to quaternary and beyond. So it depends on your relationship with the person, the contact, the level of contact, and that is determined, and there's discretion at the level of the CMOH office. So for example, if someone lives in a household, your husband is positive, you yourself and your kids live in the same household, and they do develop symptoms, they will be tested, but chances are, of course, they will be COVID if the first individual had COVID. It's very unlikely they will have anything else. So testing does occur with the symptomatic primary contacts, And we do test asymptomatic primary contacts in certain instances, for example, in children who maybe have some sort of comorbid conditions. We will do our early test just to make sure that their health is safeguarded going forward. And then, but the discretion lies at the level of the CMOH, and each case is different based on the epidemiological link that they find.
Thank you. And we go now to ACP News for one question, please.
Hi, good morning again. I just wanted to follow up. A national who is abroad and gets the vaccine, would a national be treated differently? In other words, when he returns, would he still have a self-isolate, etc.? I know you mentioned this already, but can you just give us an update? And has the policy changed with regards to that? Thank you.
No, I don't think there's enough. When Professor Carrington was on, she would have gone into detail. There's not enough evidence as yet to say that someone that is vaccinated will not be able to spread this disease at least at this point. There's a lot more research that has to go forward before we can make that determination. Out of caution, we maintain the 72-hour PCR, and we're maintaining our quarantine, at least our quarantine protocols up to this point. But of course, as things change and we get more information related to post-vaccine follow-up and how those persons go, there will be amendments to the policy as time goes by. If it necessitates, for example, and we went into discussion with yellow fever, for example, persons for years, we can't go into certain jurisdictions without having our yellow fever vaccine. So we don't know what will happen in the months to come as it relates to COVID-19 vaccine and the possibility of what people like to term immunity passports, but we have to wait on the sound research, which is already happening, to determine if people can be infected to a great extent and thereafter transmit the virus once you've been vaccinated. So as more and more people become vaccinated, more research will go into those populations to see the effect of the vaccination beyond protecting from morbidity and mortality of the particular disease. So as the data comes to us, of course, our protocols remain very flexible, and we will, based on the research, we will amend them to suit. Okay.
Thank you. And we go with final question from CNC3, please.
Okay, thank you again. So CMO, I know my colleague Kim raised this issue a bit earlier about the exemption policy, but my question is, I know the exemption policy is the remit of national security, but the way that we protect our country from bringing in the virus is one, through the exemption policy, as well as the quarantine protocol. So from your perspective as a health policy maker, are these two things symbiotic, or can they work independently of each other?
So I think they work synergistically to provide increased support. So you can have a quarantine scenario where you have an open border. You have a quarantine scenario in Trinidad where we have a closed border. So it helps, and it goes a long way, because of course the influx of people are much smaller. They are much easier to control. You know where they're coming from through an exemption process. You know their risk profile based on the history, and of course you have your PCR before. So they are synergistic in the way they protect the country, and of course the quarantine process is guided by the nature of the borders and the nature of the exemption process prior as well. So they inform each other. So they are connected.
Thank you very much, everyone. Today we looked at certain pieces of information and some strategies that we are using in Trinidad and Tobago to ensure that we proactively manage COVID-19 and that we're continuously being ahead of the curve. We also learned about the National Technical Advisory Group and some of the co-opted members from University of the West Indies, for example, and all of those strides that we are taking to ensure that any vaccine used in Trinidad and Tobago is safe and effective. And we thank you for joining us today. We really do appreciate that you take the time to view these conferences every week. Please share the accurate information that you receive today with your loved ones so that you also can help us to manage COVID-19 in Trinidad and Tobago. Thank you. Be safe. Wash your hands. Stay away from others. And of course, wear your mask.